Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Yousuf Zafar. He's a hematology oncology physician. Today's Kevin MD article is The Personalization of Cancer Care in 2025. Yousuf, welcome to the show.
Thank you so much for having me.
All right, so let's start by briefly sharing your story and then jumping into the reasons why you shared this article with Kevin MD.
Yeah, sure. So, as you said, I'm a medical oncologist with a focus in gastrointestinal oncology. I did my training at Duke University and was on faculty there for about 17 years as a clinician, as a health services researcher, and as an administrative leader. A few years ago, I decided to take the leap, try something different with my career. And currently, I'm the chief medical officer of a company called Access Hope, which provides second opinions for patients receiving cancer therapy.
All right, and your Kevin MD article is about the personalization of cancer care in 2025. For those who didn't get a chance to read it, tell us what it's about.
Yeah, sure. So as I was thinking about this article, I realized that cancer care, to no surprise, has become really complex. A mentor of mine once told me that, one day every cancer is going to become a rare cancer. Right? So think about that for a second. What that means is that the way we diagnose cancer, the way we categorize it and treat it is going to become by orders of magnitude more complex.
Hmm.
And so I was thinking about how that's happened, right, over the past couple decades that I've been in practice. And, when I first started, all we had were cytotoxic therapies
Yeah.
that, hurt patients sometimes more than they helped. There was this first evolution in cancer care, and that happened with targeted therapies and biologic therapies where the treatment got a little bit less toxic and much more effective.
Yeah.
Then there was a second wave of immunotherapy, right? Everybody's talking about immunotherapy in cancer care today. And now we are in the midst of this third wave in cancer care that's built around precision medicine and technology-enabled care. And I thought it was really important to think about how this evolution in cancer care impacts providers and has made care better and more complex. We see oncologists rely on NCCN guidelines for care
Hmm.
delivery. These are, nationally recognized guidelines for cancer care. The decision paths per cancer within NCCN has increased by nearly 400%
Wow.
since those guidelines came into play. It's mind-boggling.
So tell us about that evolution that you mentioned in terms of its impact, not only on clinicians, but for patients. So tell us the impacts on both.
Yeah, and for patients, it's been tremendously complex because a patient who is trying to figure out what is the best care that I can get,
Yeah.
they don't necessarily have a single source of truth for that. By default, as it should be, their source of truth is the oncologist who's treating them.
Yeah.
We know 80% of care that happens in the US is happening at community oncology practices. And so what we're doing at Access Hope, for example, is trying to understand how can we support the community oncologist and their patient through these ongoing, continuous waves of innovation in cancer care. And so, one way that we're helping the patient and the community oncologist is to say, all right, maybe you don't have to go somewhere else to get that second opinion. We'll bring it to you. We'll take an expert subspecialist opinion from an NCI designated comprehensive cancer center. We'll have that oncologist review your care, and we'll bring the review back to you to limit sort of delays, travel expenses, and difficulty in decision making. So that's, I think, one small piece that we can play. I'm really proud to be at Access Hope to help with that.
Hmm.
There's so much more that we can do as we think about sort of simplifying and honing down the way we deliver cancer care today.
So are there disparities in terms of the treatment options patients receive, whether they work for a large academic medical center like Duke versus a rural oncologist? So tell us about any disparities, if any, especially with the rapid pace of evolution of cancer treatments, like we mentioned.
Oh my goodness, it's a tremendous problem. And we see that just by looking at the data that's available today, right? First of all, we know there has been and sadly will continue to be inequities in care when it comes to race, gender, income, right? One aspect of inequity that we're seeing very clearly in cancer care is geography, right? Is based on geography. We know that there was the really interesting paper that came out in JCO Oncology Practice recently that found that, the majority of counties in the US don't have a clinical trial based in them.
Okay.
And in cancer care, we think about clinical trials as the cutting edge in all of medicine, right? We think about cancer clinical trials as the cutting edge of therapy. And to not have access to that is a tremendous source of inequity. We also know that patients with cancer who are living in rural areas have less access to the best care than those who are living close to an NCI designated comprehensive cancer center. So we need to think about these issues further and understand how can we impact them to decrease these, disparities in care that you mentioned.
So, in practical terms, what would that look like? Would that conceivably be if someone is, say, in a rural setting, they may get a cytotoxic option versus someone in an academic setting, they may get access to a more biologic option or immune therapy or precision oncology option? Is that what we're something like that, as simple as what we're seeing?
I think there are, structural barriers at play. Now, let's just take the example. Let's move away from my world of medical oncology and let's talk about the world of surgical oncology,
Mhm.
right? So we know that there are patients who might be eligible for a pancreatic cancer surgery, so Whipple procedure, which is one of the most complex procedures that you can get, who don't have access to the procedure because of where they live. And so they don't get surgery, even though they might be eligible for it. Again, because of the zip code that they live in, because of their lack of access to a high volume center where that procedure is performed. So there's that sort of structural barrier. Another is just in the volume of patients that are being seen by medical oncologists today. More and more practices in rural areas, hospitals in rural areas are closing down. And so oncologists are seeing, tens and tens of patients, 40 plus patients a day in some of these
Wow.
smaller rural practices. They have to treat a patient with prostate cancer in one room, go into the next room, treat a patient with breast cancer, next room, treat a patient with a leukemia. It's a lot to keep up. It's a lot to keep up with as our care is evolving rapidly. So it's practice patterns, it's structural barriers, and so much more that we have to consider when it comes to optimizing cancer care.
And are we seeing things like mortality disparities because there is such a geographic disparity when it comes to different cancer treatment options?
There is evidence out there that lack of access to the best care possible can impact outcomes, including survival. And that's not just related to some of the structural barriers I've talked about. Something that's near and dear to my heart is the financial toxicity of cancer care. That's something that
Yeah.
I spent most of my career as a researcher working on. And we know for sure that patients who are experiencing greater inequity when it comes to the financial aspects of cancer treatment, they do worse and their survival is impacted. Cancer care is complex, and there's so many factors that contribute how well a patient does. But that doesn't mean we can't think about and address all of them.
So let's talk about some of the paths forward. So for those patients that may have a geographical barrier to the best cancer care, what kind of options do they have?
Well, this is where, again, I'm so proud to work at a company that is impacting that very barrier, right? So, again, what we do is we provide that remote second opinion to an oncologist and their patient who may benefit from it in real time. But that's not it, right? We have so much more that we can look to. I think there's a lot of progress that's being made to take advantage of technology. What about remote multidisciplinary conference,
Mhm.
remote tumor boards, right? Where we can take in data from across an entire state, across an entire geography, and look at complex genomic reporting in oncology, and identify a targetable mutation that maybe a community oncologist who's sort of, up to their neck and just keeping up with first and second line treatment might not realize that that's a targetable therapy, a targetable option in the third line. So I think there's a lot that we can do to take advantage of technology today to lessen the burden on community oncologists to either one, validate the outstanding care that they are providing, which is really what should happen most of the time, or provide additional options that they might not have seen before. The key to that, though, Kevin, will be to do it in their workflow.
Hmm.
And this has been one of the biggest challenges when it comes to technology today. Somebody told me once, and I completely identify with this, and you will too, right, as a practicing
Yeah.
doc. The minute you have to have a physician look at a second piece of glass, the odds of that physician adopting what's happening on that other screen, not integrated in the EHR, starts to drop. So whatever we do, however we deliver these solutions, whether it's second opinions, whether it's multidisciplinary conference or genomic interpretation, we have to figure out how to do that within the clinical workflow as it exists today.
Hmm. So tell us a success story. What would that look like? It could be hypothetical, it could be a real story where a patient would kind of use one of your second opinion services or use some of these technological options to kind of overcome some of those
Yeah,
obstacles to receiving the best cancer care. So tell us a story of what that would look like.
sure, sure. So actually, this is something that happened to us, at our company just a few weeks ago. We, performed an expert opinion on a patient who was living in a rural county and had an advanced complex cancer. When our reviewer at an NCI designated comprehensive cancer center reviewed these patients' records, they realized that the patient's care was not aligned with the standard of care by any means. The reviewer reached out to us and said, "Hey,
Mm.
I'm looking at this case. I'm really concerned." So we said, do the review. We got the review, and in a matter of hours, right, we're then talking to the community oncologist who's treating this patient and sharing this expert review. And the community oncologist said, your timing is perfect.
Hmm.
I was really unsure about what to do next with this patient. I'd sort of reached the end of what I expected to be the standard of care. The opinion that you're providing is helping me in real time. And we also provided a clinical trial option, for this patient. And that oncologist said, this trial is something that I think my patient would be interested in. I'm gonna investigate it. So, in this case, we were able to, pick up that sort of needle in a haystack, that patient who's sort of getting care with an incredibly intelligent and well-meaning oncologist who needed help, right? And so I was, really proud that we were able to help that patient and that oncologist using our technologic capabilities and our expertise.
We're talking to Yousuf Zafar. He's a hematology oncology physician. Today's Kevin MD article is The Personalization of Cancer Care in 2025. Yousuf, let's end with some take-home messages that you would like to leave with the Kevin MD audience.
Yeah, sure. And I think, the if I think of a take-home message for me as a still practicing physician who had a long career in academic medicine and is now sort of transitioned into industry, I think the key is, for clinicians who are listening, to deliver the best care possible, we have to align all stakeholders in our healthcare delivery system. That includes patients, clinicians, payers, employers, right? And with that in mind, I sort of think of three key lessons that I listen to myself, right? Number one, don't silo yourself.
Mm.
Care delivery has to have the benefit of interdisciplinary minds. We have to talk to others outside of where we live to understand how to improve care. Don't underestimate your power as a clinician in impacting systemic change. There's so much happening out there that's supposedly impacting healthcare without the voice of the clinician, right? Be that voice.
Hmm.
Step up and be a part of the tremendous change that's happening around us. And third, I would say, if it's still okay to start small and changing your practice, paying attention to the potential disparities and inequities in your patient population, paying attention to how technology may or may not be helping your population. That's a step towards changing our system for the best.
Yousuf, thank you so much for sharing your perspective and insight. And thanks again for coming on the show.
My pleasure, Kevin. Thank you so much for having me.